Hello, everybody. It's good to be with you today and bring you a new Gyna Garage. My name's Ed Pavlik. I'm in Lexington, Kentucky, where we have coolish weather. My colleague today is,
Frank Lawton from London, UK. We have very cold weather at the present time. There's frost in the mornings and the evenings. The skies are clear. We've had no snow yet, but there's been snow in the north of the country and in Scotland. And I'm sure it's been very windy as well. We've had quite a storm over the last couple of days. Things have calmed down a little now, but I don't think we'll see a white Christmas. London doesn't do white Christmases, unfortunately.
I see. Well, today we're going to ask a question. What's the risk of ovarian cancer in older women who have stable adnexal masses? This question has some answer provided to us from the American Journal of Obstetrics and Gynecology. And basically, it's an important question because, once a mass is found, there's a good deal of worry about what to do if you're the practitioner or if you're the patient. So let me simply say this in this particular paper. The whole idea is that we can have a group of women who we survey in a retrospective sense, and we can cull that number down by excluding people who have had an elevated CA-125, and we can cull that further down for uh, removing the people who didn't come in for the second ultrasound exam that would determine the stability occurred. When we're through with the culling, what we do is have roughly 4,000 cases that are stable, where the mass is stable, and 700 cases where they're unstable. There's changes. Stability was defined in terms of several morphologies, including solid structures, septations, pure cysts, and basically those different types of things that you would see visually also were defined in terms of stability, which would have to occur in women who were more than 50 years old. And the mass itself was relatively average size, less than 10 centimeters in diameter. So we're not talking about humongous adnexal masses, but ones that are reasonably found a lot. Now, the way the qualification was run after an initial ultrasound, a repeat one was done about 6 weeks later, and the difference would determine, and basically in that time we would be looking for no difference in what the ultrasound looked like, and then the total scan sort of followed for about 4 years. During this period of time, which is cases being taken from the literature, what we have is a summary that I'm showing right now. And basically, we're calling the duration of stability the time interval from when that first index ultrasound was taken. And the concluding points that are important for this paper was that if the stable cases were looked at over the course of the surveillance period, there were 11 ovarian cancers that appeared. However, in the unstable cases, there were 12, but it was 12 out of 689, or almost 2%, as opposed to a tenth of that number. What can we get out of this that might be very helpful? Well, the authors feel that basically, if we look at the time intervals following entry into the study in a retrospective sense, that basically ovarian cancers occurred in the first year in the stable cases, and then there were some that occurred in the second year, up to the second year, and some excuse me, in the 24-month period, and then into a 24-week period, and then the rest occurred within 1 year. So really, let me be clear about this. They felt that all 11 of these cases, which they somehow numbered as 12, 8 plus 4, occurred within 1 year. And so their conclusion is that there's low probability of these things occurring, and everything will be over in the first year. this would help the triage of these particular types of cases. The problem with this is twofold. One, we don't know what would happen with the cases that are left over after the first 2 years, in years 3, 4, and 5. We don't know if just because you get a single zero in the first 2 years, no ovarian cancers, if that'll persist for the next 3 years, or or whatever. And the other one is the other situation is that there's a number of people that I've identified in red who represent the difference between the starting number and the next number, who really are not considered in the study. They're missing values, missing people that are not part of the follow-up group or the group that's being followed. The end result, though, is I think we can say that it's very reasonable to assume that once a adnexal mass is stable and continues to be stable, those probably fall in a category that they are less worrisome than those that are changing in structure and changing in size. I will say I would have preferred in this study that if the unstable cases were going to be followed, that their period during which they were being followed should have been part of this paper, which it wasn't. It should have been a column right next to this column, right here. Anyway, I think the conclusions are reasonable. They've done, a good approach from the way they've done it on a retrospective data set. And there are a couple things that, could have been done better. Frank, that's all I've got on this.
Yes, I think it's quite an interesting paper. Obviously, the problem with screening for ovarian cancer is we don't actually know the natural history of the disease. We know the natural history of CIN and its progression to cervical cancer. And we know the natural history of a lot of other illnesses. We don't know the natural history of borderline. Are borderline tumors always going to become malignant? What is the chance of malignant change in a stable adnexal mass? I don't think we know those data at all. And it's, in a way, can you reassure a patient saying, well, yes, you've got the ovarian cancer is well known. When celebrities get ovarian cancer, it makes headlines. Here's a woman who is found to have an abnormal adnexal mass, and will she be reassured by her clinician that, well, there's been no change over a 6-week period, so the chances are this being malignant is very, very low. I don't know whether that would change the patient's opinion. Is I'd rather like it in a pot in the laboratory, please, rather than my pelvis. The other thing, of course, is that they didn't follow up with CA125. They've just used ultrasound, and it may well be that the other panoply of various markers and investigations for the progression of an adnexal mass might be helped by doing serum tests as well. And the other thing, of course, is that just because you've got a 10 centimeter ovarian cyst that is not malignant doesn't mean it's not going to undergo torsion or hemorrhage. And it still may be, regardless of its potential for malignant change, it would be better have it removed. And laparoscopic surgery for a 10 centimeter ovarian mass is not going to be big problems at all. So although I think it's interesting, but they've tried to say this hopefully will try to reduce the number of ultrasound examinations in women with adnexal masses, but I don't think it's actually going to change too much of the worry of women, and for that matter clinicians. It's all very well saying it hasn't changed much over 6 weeks and nothing happens in a year, but what happens in 2 years or 3 years or 4 years?
Well, that's right. And I'll point out one other thing, and this is really splitting hairs to a certain extent, which is part of our review. But when we look at the frequency of the incidence of ovarian cancer cases in the stable group and those in the unstable group, the expectation you would have is roughly the general population expectation, which is around 7 times less than the incidence of ovarian cancer, roughly around 1 to 2%.
Yeah.
That's lived up to by the unstable cases, that incidence, but it actually looks almost like the stable cases have a 0.27% incidence, and that almost is protective, which is sort of a little hard to believe. So,
It is, yes.
So anyway, my final comment has to do with the artificial intelligence. In this case, Gemini was really sort of off the target. Uh, they they did not realize that the morphology, size and shape, internal structures of the masses that included were included. And they made a criticism that a paper that was about ultrasound only included ultrasound, which, was very sophomorish. And so they were confused as far as I'm concerned. But once again, and I'm not being paid to support Copilot or anything like that, but Copilot was spot on. So they had the correct numbers, the correct limitations, and the correct findings. So in the end, once again, we've done this with artificial intelligence, and there is a difference between the two major generative artificial intelligence things out there by Microsoft and one by Microsoft and one by Google. That's it, Frank.
Another one done.
Okay. Well, our Thanksgiving is coming up. Looking forward to it. I don't know what we're going to have except turkey, but it's coming up. So I'm grateful for you, Frank. It's great to get together with you, and though you may not have the same holiday, whatever holiday it is, I hope you enjoy it.
Okay, my friend. Thank you very much indeed.
Okay, you take care. I'll see you next month.
Yeah, bye.